Okay, so let's talk about RSV. When you look at the news, a lot of news coverage on RSV, and that stands for respiratory syncytial virus, really focuses on children. Children's hospitals filling up with RSV, young children and baby dying from RSV. But unfortunately, respiratory syncytial virus is really a problem of the young and the old and the immunocompromised. So this is just one of many articles that I could have chosen. I like the graphics. This is a group from Korea. And what they're showing here is that this is back in the pre-COVID time. So the data is a little cleaner, is that around the time when you're getting influenza in the winter months, so this is January, February, March in Korea, that's when you're getting RSV. Now the influenza is shown in blue. The RSV is shown in orange. So you can see that when they're testing hospitalized patients, there's more cases of influenza than RSV. However, what they found is that in this patient cohort, the hazard ratio, the risk of death, was 2.3-fold higher for patients with RSV compared with influenza. That's pretty significant, and that's an adjusted hazard ratio. And the variables that cause increased risk of death were increased age, chronic lung disease, and having actual pneumonia, lower tract disease. The reason for that difference is probably because we don't have good treatment for RSV the way we do for influenza. So the point is that even though RSV may be less frequent, because it's not really treatable with an effective antiviral therapy, when it does occur, it can cause significant disease, hospitalization, intubation, and death, especially in older patients, especially in immunocompromised patients. But there's good news. As of this year, we have not one, but two new RSV vaccines on the market. These are both inactivated subunit vaccines. They target what's called the F protein in RSV. And this is just a little bit of data from the GSK study. This was a phase 3 randomized placebo-controlled trial, and they enrolled over 25,000 patients in 17 countries and assigned them to receive either placebo or RSV. So if you look at this Kaplan-Meier curve, you can see the folks in blue who got the placebo had a cumulative incidence of getting RSV. It looks like it's about 0.3 or 0.4%, while the folks who got the actual RSV vaccine had a much lower incidence of getting RSV, more like 0.1%. So that vaccine efficacy is 82.6%, over 80%. And that's what led to FDA approval of this vaccine. Now, in terms of side effects, adverse events, they were generally mild to moderate, and they're exactly what you would expect from a vaccine, especially a vaccine that has an adjuvant. So folks did have more solicited adverse reactions, and the reactions were generally pain at the vaccine site, 60% in the vaccine versus 9% in placebo. And vaccine recipients were also more likely to report fatigue compared with placebo. But still, these were very good numbers in terms of preventing lower tract respiratory infection. And so this data has led the ACIP to recommend one or the other of these vaccines. They gave them a little bit of awkward names, in my opinion. The GSK product is called RSV, and the Pfizer product is called Abrysvo. They're both, I find them a little hard to pronounce, but basically pharmacies are generally stocking one or the other, probably just based on their supply chain. Both of these have excellent track records in terms of preventing RSV-associated respiratory tract disease in older patients. I just showed you the GSK data, over 20,000 participants with excellent safety data. The Pfizer product had similar excellent efficacy, over 80%. This was also studied in patients who are 60 and up. They also studied over 30,000 participants all over the world with very good safety data, with about a 1% incidence of severe, what's called reactogenicity, which is generally fever, fatigue, and pain at the vaccine site. So ACIP, and that is the branch of CDC that makes recommendations for vaccination. They're recommending that adults over 60 receive a single dose of RSV vaccine prior to respiratory virus season, guided by the patient's risk for disease and at the healthcare provider's discretion. So they're leaving it a little open-ended, but the risk factors that they mention in their recommendation are chronic medical conditions, which would be immune compromised, transplant patients, kidney disorders, lung disease, as well as frailty. And they do state that it's okay to administer with influenza, but there's no data on co-administration with other vaccines.